Hello, everyone. This is Mark Plaster, Senior Executive Editor of Emergency Physicians Monthly, and you're listening to EP Talk, a place where emergency physicians, aka ER docs, come to talk about things that are important to us, both professional and sometimes personal. And my guest today is Dr. Lisa Moreno, and who is the president of AAEM, and it's a pleasure to have you, Doctor.
Thank you so much, Dr. Plaster. It's really a pleasure for me to be here.
Thank you. Thank you. I was in Delaware at the time, and I remember when the Rape of Emergency Medicine was published, and there was that was sort of the impetus of trying to push for an organization that represented rank and file over corporate and even over society emergency physicians. And so I thought that the entire motive of its birth was very noble. And you're still doing that sort of work. So tell me a little bit about, we've got some things we want to cover here. We want to talk about AAEM's support of workplace fairness. Tell me what AAEM is doing in that regard.
So that, you captured it really well. AAEM was founded on the concept of workplace fairness. So we don't just believe, we know that the emergency physician is at the core of all emergency care that is rendered to every single patient. And so we take that dyad of the emergency physician and the patient, and that is where we focus our energy, and that is who we're interested in advocating for and protecting. So for the emergency physician to be able to do his or her job appropriately, that doctor needs to know that the only thing they need to be concerned about is what is best for the patient. For any emergency physician, you should be going to work every day thinking only about what is best for the patient, and that if you are a good doctor and you do the right thing for your patients, that you should not have anything else to worry about. Unfortunately, when corporations are involved in the practice of medicine, there are other things that come into play. They are, rightly so, because a corporation in a capitalistic society, which is what America is, needs to be interested in making a profit for its stockholders. That is their fiduciary duty. But that's in direct conflict with my fiduciary duty to do the best thing for my patient. So what we want to see for emergency medicine physicians is that we have due process, that there are open books so that we know what's being billed in our name and how that money is being allocated, how much to us, how much to the corporation, how much to the hospital where we work, et cetera, et cetera. And we don't think we should have non-compete clauses. So what is due process? Very simply, due process is a constitutional right that is given to us by the U.S. Constitution. And it says that if you're charged with something, you need to be told what the charge is.
Yeah, but when you say you're not charged with something, emergency physicians are often not charged. Give me an idea where due process, in a court of law where someone's charged with a crime, I understand that. Right. But let's talk about due process as it pertains to physicians. What are you talking about there?
So when we talk about due process as it pertains to physicians, we're talking about whether you get told why you're being fired or why you're being suspended or why you're being taken off the schedule. So it's kind of like the same principle. If you're going to take an action against me, you have to tell me what action you're taking against me and why. What did I do to make you decide that I can't have shifts on the schedule anymore, that I can't work for you anymore?
Yeah, okay. I mean, that's certainly employment law now is pretty stringent with that. You've got to have a process whereby you make a complaint, you have the employee is given a chance to improve, getting a chance to defend themselves, to explain why they did what they did. So that's what you're talking about as far as due process.
That is what I'm talking about. But what happens is that for many corporate medical groups, the contract says that the physician is an at-will employee, which means they can be fired at will without being told why they're being fired. And when you sign that contract, you agree to those terms and you waive your right to due process.
How can AAEM advocate for due process? How do you actually go about that? You talk to employers, you take positions, I mean, I understand and completely support what you're doing. The question is, how do you advocate for due process for emergency physicians?
So here's what we do and have done. Number one, we have lobbied really hard in the halls of federal government, in the Congress and in the Senate. And very recently, Dr. Raul Ruiz, who is a congressman from California, a Democrat, and
Mhm.
Dr. Marshall, who is a Republican congressman from from Kansas, Dr. Roger Marshall. They have together sponsored a bill that will make it illegal for any third party to ask that an emergency physician waive their due process rights when they sign a contract.
Okay.
So this is huge.
Where does that particular legislation stand at the present time?
So HR 1169 has been introduced. It's gotten a lot of co-sponsors, a lot of support from other congressmen. It is being introduced to the floor of the Congress. Unfortunately, with all that's gone on with COVID and some of the other issues that have taken place with the recently contested federal election and the hearings that took place around that, it's been postponed, but it is actively going to be debated on the floor this year.
Has it already been through? Because I know it has to go through committee first.
Mhm.
Has it come through committee?
Yes, so it's been introduced.
Okay. So it's actually been heard and debated in committee and has been pushed forward to the agenda. However, if it makes it to the agenda,
Right.
and you anticipate that it will.
Yes, and so we're actually very excited about this because this will end the battle. Once it is illegal for a corporate medical group to ask a physician to sign away their due process rights, we've won. The deal is done. And now we know that when our doctors go to work, they don't have to worry about getting fired because they're ordering too many CAT scans or because they admitted a homeless person or because they complained that the waiting room has patients waiting there for 8 hours and we need a second doctor on this shift. We can now advocate for our patients and do what's right for them without fear of retaliation.
Yeah, I saw where a physician, back when there was a lot of debate about the efficacy of hydroxychloroquine, and there was an emergency physician who was prescribing hydroxychloroquine, and you can debate whether it's effective or that sort of thing. But apparently, she was relieved of her duties at a hospital because she was prescribing hydroxychloroquine, which is fascinating, to be relieved of your clinical duties because your employer didn't like what you're doing. I found that interesting.
No, it is interesting and it's really critically important because we should be making the clinical decisions about our patients. We're board certified. We keep up our certification. I mean,
Yeah,
that's how AAM defines an emergency medicine specialist, as someone who's board certified and who maintains their certification. So if we're doing that, how can an administrator come down and tell us how to practice medicine?
yeah. No, I agree. I happen to agree with that. And so, is there, in the situation where a physician is fired, not given any further shifts, however you want to go about saying that, does AAEM provide any kind of representative services in the form of help with legal representation or anything like that? Is there something else beyond legislation that AAEM does?
Yes, we surely do. So we get emails and telephone calls from physicians every day. We literally get about 10 a week, and either I or a member of our executive board calls those patients back and has a conversation. I'm sorry, calls those doctors
Yeah.
back and has a conversation with them about what happened. And we do have a legal committee that also can provide some guidance, understanding that it's not a lawyer a lawyer-client relationship. I mean, they don't actually have a contract, but they can get some guidance to see whether they have a case. And if they have a case, AAM very frequently will give them monetary support in order for them to get their case into court. Because we know that if you're fired from a job, you may need some monetary support in order to have your case heard.
That's terrific. That's absolutely terrific. Let's talk about open books. You mentioned that one of the pillars of AAEM's policy or goals is that every emergency physician would have open books concerning their billing, what is billed on their behalf, and that sort of thing. Let's talk a little bit more about that. Flesh that out for me. How is that? Does every emergency physician, even in a small group, see that sort of granularity on their billing?
So it's there, it exists, and in small democratic groups that have the Workplace Fairness Certificate from AAM, all of those make those books available openly to every physician. That doesn't necessarily happen in every other setting, and it certainly doesn't happen in corporate medical groups. So you don't know if your charts are being upcoded, which could leave you open to Medicaid fraud, to insurance fraud. You don't know if you worked really hard on a critical care case and I'm just making up numbers, if it possibly earned, $2,000 and the hospital fee was, $500, and what happens to the other $1,500? Do I earn it? Does my group of emergency physicians own it? Or how much of it goes to the corporate medical group? And corporate medical groups take unbelievable amounts of money. On average, most billing and coding companies take approximately 7%, but corporate medical groups take up to 30% for the service that they're providing. And the physicians are not aware of this because the books are closed, and that's a condition of the contract.
I see. And so a lot of it has to do with the goal of AAEM is to make sure that there is fairness and openness in the billing of the that goes on. If you want to find out that your employer is in fact taking 15, 20, 30, 40% of what you're generating, you can find that out. Is that the idea of open books?
Yeah, that's our idea. And for example, some large groups have multi-specialty contracts with the hospital. So they manage emergency medicine, they manage anesthesia, they manage the hospitalists. And let's say that, the hospitalists are losing money. They're not practicing effectively. And the emergency physicians are practicing very effectively and they're making a big profit. Well, the corporation can divert that profit to support the hospitalists. And we don't think that that's fair. If the emergency physicians are working effectively and efficiently and hard and seeing a lot of patients and having good outcomes, then the emergency physician should be entitled to the profits that they're generating.
I don't think you're going to find any any disagreement among emergency physicians about being paid for what you do. So I think that's pretty clear. I think everyone is probably familiar to some degree with the idea of a non-compete clause, but I'd still, for those who might not, tell us about how some of the disasters. The best way to explain a non-compete is to look at some of the disasters you're trying to prevent and the implications or applications of a non-compete clause. Tell me about that.
So non-compete clauses, which interestingly enough, our new president would like to make illegal for everybody, our President Biden, but non-compete clauses are designed to protect the skills and intellectual property of someone. And in medicine, the most commonly understood example is that of, for example, the plastic surgeon. So if I develop a facelift technique that is unique to me and I'm getting amazing results and tons of patients come to me and I expand my practice and I teach my technique to other doctors, and then one of those doctors says, I'm going to open my own practice and I'm moving down the block from you. And I'm going to take my patients with me and I'm going to take the technique that you taught me and I'm going to use it. So that doctor is competing with the doctor who developed the technique. So The doctor who develops the technique may put into his contract with his employee physicians a non-compete clause. If you leave me, you have to go at least 200 miles away, or you have to go at least 250 miles away. That makes sense. But in emergency medicine, when we learn a better way of doing something, we're posting it on YouTube. We don't try to keep trade secrets. We want everyone to know what the best way to do something is. We don't have private patients that we take with us when we move. And, when I talk to residents, I tell them, you all know that there are patients who think we're their private doctor, but those are the ones that you kind of want to go to, say to them, go to another hospital.
Right, exactly.
So we don't have that. But when you have a non-compete clause in a corporate contract, and the physician can be fired at will and not told why they're fired. So the physician is fired, and then the physician is told, but you can't work anywhere within 200 miles of this hospital. And so where we've actually seen this happen is a situation where a physician was married to an attorney, and she was a partner in her practice, and she said, I've worked for 30 years. I'm not going to quit my practice and leave. And he had 3 school-age children, and one was a high school senior, and she said, I'm going to the prom with my boyfriend, and I am not going I'm going to graduate with all my friends that I've been going to school with since kindergarten. And this physician had to get a studio apartment in another city where he lived 3 or 4 days a week. And then he would come home on the other 3 days that he was off and spend the time with his family. Now, we did not go to college, medical school, residency, incur a bucket load of debts in order to live apart from the people that we love.
Yeah.
This is not fair to doctors. It's not fair to emergency physicians.
Why would a group want to have a non-compete? Tell me that one. I don't understand that.
So I don't know the answer to that question. We would have to get them to tell us. They say that it's because of trade secrets, but in emergency medicine, we really don't have trade secrets.
Right. That's true. Let's talk about number 2 on your list of goals or commitments from AAEM. You've talked about patient safety. We've talked a lot about doctor safety. I just did a podcast with someone who had a new product that was able to protect doctors from violence in the ER. But you're talking about patient safety. Let's what are the goals of AAEM, and how are you going about advocating for patient safety?
Well, one of the things is that patient safety is incredibly tied to due process. So a doctor has to be able to do the best thing for the patient. The best thing for the patient is not always the best thing for the hospital or the corporation. And I gave briefly a couple examples earlier. So if you're homeless and I need to admit you to the hospital, that's not good for the hospital. They're not going to get paid.
Yeah.
But it's the best thing for my patient. It's the safest thing for my patient. If I feel like my patient needs a CAT scan, even if I've already ordered 2 other CAT scans on that shift, I shouldn't be held to a standard of, am I ordering the average number of CAT scans per shift? Because we all know that our practice varies. Who we see is different every day. So for my patient safety, I have to be able to make that judgment. What if my patients are waiting in the waiting room for 4 or 5 hours? We had a physician who saw a patient who had a stroke while in the waiting room. But by the time the patient actually got into a room in the ED proper, the patient was outside the window and nothing could be done. And the patient had a poor outcome. And she complained that this was a patient safety issue, that they needed to have more physicians in the emergency department on those shifts, and she was fired. So nothing was done to protect those patients. Nothing was done to prevent that from happening to another patient. If we are to be empowered to do the right thing for patients and to speak up for patient safety, we should not be worrying about our jobs.
So you're really talking about physician judgment empowerment to place the physician in the driver's seat to make patient safety decisions. I think if I could say that, put the words in your mouth, you're saying that an independent physician who's not feeling the pressure from the hospital or his corporate employer is going to make an independent decision on behalf of the patient and their safety more likely than one who feels the heat from upstairs, so to speak. If I could put that summary to what you've said.
No, and you're exactly right. And let's just take a step back and think about how ludicrous it is that we have to even say these things. Where are we in the spectrum of controlling our practice? We are doctors. We went to school and studied hard in order to have abundant knowledge about what is the right thing to do for a patient. And yet we've come to the point where non-physician managers are telling us how we should take care of patients. Now, if a plumber came into my house and he told me, this is how you need to run the pipes for that new bathroom you want to add onto your house, I wouldn't dare to question him because I'm not a plumber. I didn't train for that. I don't know what the best way to run the pipes is. And yet we allow administrators to come and tell us what is the best way to practice medicine. That defies logic.
Yeah. No, not. I think you're speaking. You're what do they say? Preaching to the choir on this one. Let's talk about your last talking point, which is an interesting one here because said AAEM's commitment to diversity, equity, and inclusion and leadership development. There's an interesting term here that I want to parse out with you. A lot of people talk about equality of opportunity versus equity of outcome. Is that what you're meaning?
Pretty much everybody knows what diversity is. That's not the hard part. It's the equity and inclusion that kind of is the hard part. So the difference between equity and equality is that when we create equal opportunities, we put an opportunity out there and we say that this is open to everyone. I'm not going to discriminate, that famous clause. I'm not going to discriminate on the basis of race, religion, gender, sexual orientation, et cetera, et cetera. So here's the opportunity. So if I, for example, have a bunch of food, free samples, whatever, and I say, I'm going to put them out there and it's for everybody. It's for everybody. And I'm going to put them here on this shelf that's 6 feet off the ground and everybody is welcome. But reality is, how do you get something that's 6 feet off the ground if you're a kid? How do you get it if you're under 5 feet tall? How do you get it if you're in a wheelchair? So I may say that it's for everybody and I may not discriminate against everybody, but everybody doesn't have equal access to it. Equity is giving everyone the tools that they need to be able to access every opportunity. And so in medicine, we recognize, I'm sorry, go ahead.
No, I'm listening. Because I've heard a different definition of equity. I've heard equity as equality of outcomes. So that if you have if you say everybody has access to this food, and you have 5 people who are 5'2", and 5 people who are 5'10", and 5 people who are 6'5", that everybody has equal food. And so you actually make sure that everybody has equal food, which is an outcome. So, and that's what I've heard from others about equity, meaning that it doesn't matter how, it really is not is no longer meritocracy. It's purely numbers based on whether you meet a certain description or not. And usually it's race, but it can be sex, it can be sexual orientation, it could be a variety of things. If that number is of the population is 15-20%, then 15 to 20% of physicians need to be that description. And so I've heard that as an equity, an equity argument, an equality of outcome. Is that not what you're meaning?
So that is not what I mean, because there's more to it. So, for example, when we look at COVID, And we see that, and the example that you've used is the example that I use when I do lectures on research, because I have a master's degree in clinical research, and we know that that is true. What you said is exactly true, that if 16% of the US population is Latinx, then 16% of the people who contract COVID should be Latinx. 16% of the population who dies of COVID should be Latinx. If 13.7% of the population self-identifies as Black, then 13.7% of the population of prison should be Black. And 13.7% of the population of individuals who are HIV positive should be Black. So that's when we talk about equity of outcomes. But I take things a step further when I talk about equity. If you don't see those equity of outcomes, it is because there is a variable at play. And as a researcher, it is my job to find out what that variable is. And so when you talk about medical education, why is it that 13.7% of medical students are not Black and 16.3% of medical students are not Latinx and 2.1% of medical students are not Indigenous American Indians? Why is that? That is because there is a lack of equity, because the public education that is provided to those underrepresented populations is inadequate, because the socioeconomic status of those populations is inadequate. They cannot afford to incur all that debt to go to medical school when they have children that they have to support, when they have parents that they have to help. When you look at the factors that are preventing the equity of outcomes and you mediate those factors, you ameliorate those factors, you intervene on those variables, then you are creating true equity.
And so, so the question here is, why is the American Academy of Emergency Medicine concerned with this, and how does it relate to emergency physicians? And what is AAEM doing in regards to what is admittedly a social issue? Why is AAEM involved in this? You know, the question is, what's it got to do with the what's the connection? What's the nexus to emergency physicians?
So the nexus to emergency physicians is that, for example, if 50%, and some are saying now it's 51% of medical students are female, why is it that 63% of emergency physicians, 63% of emergency medicine residents, and 63% of the applicants this year to the match for emergency medicine are male? Mm-hmm. Why is that? So we want to look at those things. Why are there not more Black and Latinx members of our specialty? And why does AAEM not have a membership that is 2.1% American Indian, 16.7% Latinx? Why? And so we're looking at those factors and we're trying to take measures to reach out to individuals, just like Dr. Ryder and Dr. Rogers reached out to me and said, you know what? We don't look diverse, and we know that we don't look diverse, but that doesn't mean we don't want to be diverse. And so we want to have you run for the board, and we are going to mentor you. And what I'm doing as president of AAEM is paying it forward. So we are making concentrated efforts to reach out to individuals who are underrepresented so that we can have those equitable outcomes by altering the variables that are preventing those equitable outcomes from occurring.
So that's how that diversity, equity, inclusion is involved in the leadership development. You're the classic example, is what you're saying, is in an effort to have a membership that is reflective of national percentages of women and people of color. I mean, whatever that might be, whether it's there's a variety of different identities that could be reflected, but that AAEM has specifically wanted to develop a leadership panel that is reflective of the percentages in the community. Is that fair to say?
That is fair to say. In 2003, the Institute of Medicine report said that the composition of physicians should mirror the composition of the community that those physicians serve. That was in 2003, almost 20 years ago, and we've gotten nowhere near it.
Yeah.
So,
And do you think it's because of lack of opportunity, or is it, is it possible that other opportunities are more appealing to those populations? If you could do anything you wanted to, do you think we would always divide exactly according to population statistics?
so the odds are that that would be right, because that's the way the universe works. That's what we learn as researchers. But people are not given the same opportunities as other people. I had a secret fantasy dream of wanting to be on the board of AAEM because I believe in the principles and the integrity and the ethics of AAEM. But I looked at the board of AAEM and I said, they don't want people like me because nobody looks like me. And so I kept it a secret, my secret dream and fantasy, and was afraid to do anything about it because I didn't want to get rejected by reaching for something, by trying to make myself a part of a group that I didn't think really wanted me. And it wasn't until the president and the president-elect of the board cornered me in the hallway in an AAEM meeting and said, we see you. We see your hard work for AAEM and we want you, even though we don't look like we want you, but we want you and we know that we need to be more diverse. And so I have used my position and the support and mentorship that those men have given me, that those white men have given me, because they recognized their privilege and they reached out of their privilege to create an opportunity for me. And so now our board looks really different because of that. Our board has quite a few women on it. Our board has some brown people on it. Our board is changing. And the Leadership Academy that I did this year, I'm extremely proud of. We had 92 people in the Leadership Academy, lots of women, lots of people of color, lots of people from diverse backgrounds. And all of these people are going to be groomed to be leaders in AAEM and beyond. I want you to get a promotion academically. I want you to become medical director of your shop. I want you to do whatever it is that is your secret dream and fantasy, just like I had my secret dream and fantasy.
Yeah, I had a secret dream. I had a secret dream and fantasy in high school and college. I was playing basketball. I wanted to play the NBA, but nobody really reached out to me to mentor me into the NBA. I might resemble, an NBA player in some regards, but no, I that wasn't in the cards for me. Well, Dr. Moreno, thank you so much. You've been a delight to speak to, and you have certainly given us an insight into the goals and of AAEM. And I think that our listeners, some of whom are AAEM members, some who don't understand or know about the history of AAEM and its advocacy for physicians of all races and ethnic groups. So thank you very much for joining me today, and I hope that our listeners will continue to reach out and to AAEM, and if that's something that appeals to you, then Dr. Moreno is the connection for that. So thank you, and for all of our listeners, thank you for joining EP Talk today, and we hope to see you again. Thank you.